Okay, Richard Kelly is going to talk to us about mental health of medical and legal professionals. Richard's a board-certified anesthesiologist, teaches at UC Irvine, graduate of Harvard College, law degree and medical degree from Stanford. He's an emeritus editor-in-chief of our Journal of Legal Medicine. And very important for this meeting, he's brought with him his wife, Mary, who is keeping us on schedule and has us organized and has us with the right materials. So I'm going to get out of the way and we're going to hear from Richard Kelly.
All right, we're up. All right. Very good. Thank you. Thank you. So I am, in real life, I'm a cardiothoracic anesthesiologist. And so I spend most of my days inside an operating room watching after patients who are asleep under anesthesia. I tell my patients, I put them to sleep for free. They pay me to wake them up. So, every day I actually spend my time, I handle pharmaceutical grade fentanyl at least 5 or 6 times a day. And so now today we're going to talk about a different population. We're going to talk about the population of educated people who are abusing substances. There we go. Went too far. Let's go back one. Don't know what's going on with this. Oh, this thing. Got it. Thank you. Okay, so today we'll talk about the prevalence of substance abuse among professionals. Physicians have been studied quite closely, and anesthesiologists even more so. We'll talk about psychiatric comorbidities that accompany substance abuse. And I think this has been alluded to by a number of other speakers. There are underlying problems that people have, and they use substances, illegal substances, in order to assuage whatever mental or emotional trauma that they have. We'll talk about risk factors among professionals for developing substance abuse disorder, how the disease progresses, and then we'll turn to the medical and legal ramifications of abusing substances among professionals. And obviously, they're all very motivated to return to work. And what is their, how do they return to work, and what is their probability of relapse? Now, I think you've seen this slide and the next slide, which is of Sigmund Freud. These are probably the only 2 pictures of them on the internet because they were shown before. But actually, this guy is very interesting. He's William Halsted is considered the father of modern medicine. And he actually is responsible for the aseptic technique. He was the first one to actually wear gloves in the operating room while operating. He was the first person to actually extract stones out of a gallbladder. He actually did that, the story goes, he did it on his mother on the kitchen table, but she survived. That was before he discovered the aseptic technique. He was the first one to actually do a blood transfusion on his sister. His sister had postpartum hemorrhage. She was dying from loss of blood. He stuck a needle in his vein, drew out the blood, and infused her with it, and she survived. And he was very interested in all sorts of things to do with science. And when he was 32, he saw this paper that came out of Austria about using cocaine to numb up local areas. He knew immediately that was, after he read the paper, that they were doing it slightly wrong because they didn't understand where the nerves run. So he decided to do some experiments himself, and he began to inject himself. He became his own patient. He injected himself and soon became addicted to cocaine. He also injected some of his students, and one of his students ended up dying. But he is also the father of Johns Hopkins, and also was known for a number of other achievements. But as he realized, as his cocaine addiction progressed, he realized that he was in trouble. So he turned to his colleagues, who then advised that he take morphine in order to cure himself. And he then became addicted to morphine as well. So he was not any low life person, but he had an addiction that he couldn't shake. We talked about Sigmund Freud as well, the father of psychoanalysis. And he actually thought that cocaine was going to be the miracle drug. And he used it quite often. And he wrote a number of papers touting how good the drug was until some of his colleagues started to get addicted and advised him not to write those papers anymore. But he, even after that, he continued to use cocaine on a regular basis. And he used it to treat his depression. He was also addicted to tobacco, and as was mentioned before, he died of squamous cell carcinoma of the palate. Okay, so we're talking about a different population of people here who are abusing substances. And let me tell you this story about Dr. Smith. Dr. Smith had gone to a good college, had gone to medical school, had trained as an anesthesiologist, and then went out into private practice. He went to a small rural hospital and where he practiced and raised his family. He was married. He had a 6-year-old son who had some developmental disabilities, and he had a 4-month-old daughter. Things were going well. He was well respected in the hospital. The nurses liked him. His patients liked him. He did a very good job. And on weekends, he liked to go hiking in the woods and up in the mountains. And one weekend, he was hiking and he ran out of water. So he decided to fill his water bottle with some water from a stream. He thought nothing of it and returned to work on Monday morning, felt fine. But then on Tuesday, while he was in the operating room, he started to get acute abdominal pain, nausea, explosive diarrhea. He excused himself, went down to the emergency department in this small hospital. They ran a bunch of tests. They discovered that he had giardiasis, which is a parasite that goes in mountain stream water. They prescribed Flagyl for him, and they also prescribed a narcotic for him for the acute abdominal pain that he had. He went home, spent a couple of days at home recovering, took the narcotics for pain control, took the Flagyl, felt much better, came back to work the following Monday, felt like things were okay, but sometime in the afternoon, he actually started to get the abdominal pain coming back. It was pretty bad. And instead of going back down to the ED to try to get another prescription for the narcotic that he had been prescribed, he decided he would just use some of the fentanyl that was around that he was giving to his patients, because we give almost every patient in the operating room a pharmaceutical grade fentanyl. So on his break, he took some of that fentanyl into the men's room and injected it. And he told me years later that the moment that he injected that, he knew he had a problem. The euphoria was so great that he knew that he would never be able to get off this drug. And so over the succeeding days, weeks, months, he developed dependence on it. And we've talked about dependence, which is when you don't have the drug, you will suffer withdrawal symptoms. And also there's this idea of tolerance, that over time you're going to require more and more of the drug in order to meet that need. And so he started diverting more and more of the drugs. It became more and more of a focus of his attention. And so he started to have some marital problems because he was going home, he was sleepy, not really paying attention to his children. And eventually his wife found him passed out next to the 4-month-old daughter and asked him to leave the family home. He continued to work. And then one day he was working in the operating room. Another colleague came in to give him a lunch break. We'll call him Dr. Jones. Dr. Smith took some fentanyl with him on his break. And after 30 minutes, Dr. Smith wasn't back. So Dr. Jones called out to the front desk and asked them to go look for Dr. Smith. They looked all over the place, and then they finally found him in the men's toilet, passed out. They called the rapid response. They brought a gurney up. They took him down to ED. And as he woke up, he said that he was suffering from some kind of flu, felt very dehydrated, and passed out in the men's room. He did not. He didn't even mention that he had taken some fentanyl. They put an IV in him, rehydrated him, and sent him home for a couple days. But there had been rumors that had been swirling around the hospital about possibly Dr. Smith being on drugs. So the chief of the hospital and the chief of anesthesia got together and had a discussion. They had never seen this before. They didn't know what to do. So they called up a rehab center that they knew treated physicians and got some advice. After they talked to them, they went around and they started to question the OR staff. And yes, indeed, they had noticed that Dr. Smith had been acting unusual. They went to the PACU, and the PACU nurses were saying, yeah, all his patients are coming in extreme pain, yet his charting shows that he's giving them more than anybody else. So they really felt that they had enough ammunition. After a couple days, Dr. Smith came back to work. In the morning, they brought him into the room and had their intervention. They said, we think that you're abusing drugs. He completely denied it. And so they presented him with evidence. He continued to deny it. And so he said, and then they said, we would like to have you evaluated by a specialist. And he said, I'm not going to do that. I'm going home. I'm not going to participate. So at that point, they got on the phone with the rehab center and got the person that they had been talking to. The person at the rehab center talked to him and said, well, if you leave, you're going to have your medical privileges immediately suspended. The hospital is going to file an 805 report with the medical board. The medical board is going to do an investigation, and you may end up losing your license, and then you'll be reported to the National Practitioner Data Bank. So knowing that information, he said, okay, well, I'll go and get an evaluation, but I know you guys are all wrong. And so the chief of staff and the chief of the Department of Anesthesia drove him directly to the addiction specialist, had an evaluation, got a urine drug screen. The urine drug screen was completely clean. But the specialist said, yes, I do believe you are abusing drugs. Again, total denial, and said, yeah, look, my urine drug screen is clear. I must not be abusing drugs. So the recommendation was that he go to inpatient rehab. Again, he resisted, but with the threat that he would lose his license and be suspended from the hospital, he decided to go. Once he got to the rehab center, he continued to deny that he was addicted to fentanyl. But then within 4 or 5 or 6 hours, he started to suffer withdrawal symptoms. They treated him with Suboxone and got him through the most acute phase. Then they went on to actually evaluate him psychotherapeutically. They got him into a group therapy with other physicians who had been addicted. And after about a week or so, continued to deny it. Once he heard other physicians' stories of their own addictions, he began to accept the fact that he wasn't all by himself. And I think this was mentioned before, that you need a community of people that will support you in this. So it broke down his denial, and then he began on the road to recovery. So what is it that puts physicians at risk for substance use disorder? Well, some of the same characteristics that make them good doctors also makes them at risk. They have a very strong drive for achievement. They're conscientious. They tend to work through, even if they're sick, they will still come to work. They have this great drive. And when all that starts to build up, sometimes they turn to drugs in order to assuage whatever pain they may have. High work stress as well. We work in a highly stressful environment in the operating room. Surgeons, anesthesiologists, ER docs, and others in other environments, critical care environments, are high stress environments in which they are dealing with people's lives, sometimes moment to moment, having to make important decisions that have true consequences. And so this actually builds up, and sometimes it causes substance abuse. Burnout. We deal with some emotionally charged issues, very long hours, and the emotional strain sometimes leads to emotional exhaustion, and they also are at risk for turning to drugs. Also, it is our access to prescription drugs. Every day, I draw up fentanyl into a syringe. It's a clear liquid. I could very easily put saline in there and then keep the fentanyl for myself, and nobody would know any better. I could walk out of the hospital with a vial of fentanyl, and nobody would know. Nobody searches me coming in. Nobody searches me coming out. Nobody even asks. So it's very easy to divert drugs. As far as those that abuse drugs and the favorite drugs per specialty, actually, it turns out that the specialties that abuse drugs the most are anesthesiologists, ER doctors, psychiatrists, and family practitioners. For surgeons, it seems the drug of choice is alcohol. That it turns out that The relative rate of alcohol use is highest among female surgeons. About 25, in one survey, about 25% of the female surgeons that were surveyed met the criteria for alcohol use disorder, and 14% of the male surgeons met the same criteria, whereas in the general population, it's about 6%. So it is pretty high. For psychiatrists, the drug of choice is benzodiazepines, partly because of easy access, and also perhaps because they see the salutary effects that they have on their patients. For emergency medicine docs, emergency medicine docs make up about 3% of the entire physician population, but they make up about 15% of those who are in rehab. Their drug of choice, about 50% of those that were surveyed, alcohol was their drug of choice, 38% abused narcotics, 10% abused cocaine, and in a separate study, they were more likely to abuse marijuana than any other specialty. Of note, they also have the highest burnout rate of any of the specialties at about 60%. Pediatricians have the very lowest rates of substance abuse, and then we have anesthesiologists. Now, anesthesiologists, because of easy access, they tend to abuse narcotics over any other substance. In one survey, 40% of those that were in rehab were there for narcotics, and only 10% were there for alcohol abuse. More recently, there was a study that showed that propofol is actually, abuse of propofol is actually skyrocketing. And then they also looked at, there's another study that looked at the difference between anesthesia residents and anesthesia attendings, it turns out for anesthesia residents, 39% of those that were in rehab were there for opioids, 20% for propofol, 15% for alcohol abuse, whereas for the attendings, 50% were there for alcohol and 24% were there for opioids. Now, there is association between psychiatric illness and abuse, and I think this was brought up by Judge Stoner. It turns out that in this particular study of 99 physicians who were in rehab, there was about 30%, a third of them had no psychiatric disorder, but 2/3 of them did. And of those, 33% had a major depressive disorder, 12% had bipolar disorder, there was antisocial personality disorder in 7%, generalized anxiety disorder in 7%, and social phobia. There was a second study that was done a couple of years later in a different state, at a different rehab center. They had 157 physicians that they were studying, and the results were about the same. In this study, 3/4 of the people that were in rehab actually had some coexisting psychiatric disorder. Only 25% didn't, and they were similar. That there was major depressive disorder, bipolar disorder, antisocial personality disorder, and generalized anxiety disorder. So psychiatric disorders go along with substance abuse. And how does a drug progress in somebody who is a physician? And probably this applies to just about everybody. But for physicians, they actually have easier access to it, so they're somewhat easier to study. But the earliest symptoms are discord, usually in the family unit. As the physician starts turning his attention to getting more drugs, procuring it, taking the drugs, preventing withdrawal, then they're not paying attention to what's going on at home, and there tends to be discord. There is also social isolation. They know that what they're doing is wrong, but they're developing addiction, and so they try to avoid other people because they don't want to be detected. But they also get depressed because what they're doing is against all their entire value system. And once it progresses to an active disease, they start to have financial troubles. They are either selling things in order to get the drug, or that they're not paying attention to finances. They get into legal entanglements. They may get DUIs. They may be arrested for spousal abuse. And then they sometimes engage in behavior such as excessive spending. As the disease advances more, they do things that are contrary to their values. They'll start stealing, they'll start lying, and they know this is all wrong, but they can't stop it. So they have feelings of shame, and also they become very pessimistic about their lives, about their careers, and so they're at increased risk for suicide. And then as it advances, they start to become cognitively impaired. Obviously, these are people that you don't want taking care of patients. They exhibit poor judgment, they have impulsivity, and they have difficulty in modulating effect. So you see some physician in the hallway who explodes at somebody else or a nurse for no reason. You can suspect that maybe they are abusing other substances. But work performance is usually the last thing to go. The first thing is usually the family. They know this. They're discord within the family. But because physicians know that the hospital is the source of the drug and also the source of their income, they'll put on their game face when they come into the hospital. So if you detect a substance abuse or somebody that you think is abusing substances in the hospital environment, you can pretty much be assured that the disease is fairly well advanced. So what are some of the clinical manifestations? Well, there's changes in mood and affect. Well, and also it's very difficult to generalize, because if they're abusing benzodiazepines, that's a very relaxing drug. It's an anxiolytic. If they're abusing cocaine, it's something that's very uplifting and charged. So, but if they're changing the mood and affect, if they're coming off the drug, they may be a little depressed. If they're on the drug, they may be euphoric. So you can see the changes in their mood. Decreased productivity. Now they're concentrating more and more on obtaining the drug and less on doing their job. So you'll see more absenteeism, especially if they get high overnight and then they just can't get up in the morning, or they're taking frequent breaks in order to shoot up, or they're late for work for some reason or other. You'll see all of that. Increased number of errors. Sometimes it's inadvertent, they're not paying attention, or sometimes it's deliberate in order to hide the diversion. They'll be mischarting in order to hide that. They'll have inconsistent hours or volunteer to take work overnight, so they will not be spotted when they're taking diverting drugs. There might be increased complaints about their performance from other people, such as packing nurses or the operating room staff. And then there might be evidence of diversion, either charting errors or finding vials in the wrong place. And then also, as the disease advances, their appearance becomes more disheveled. They're really struggling to keep everything together. And so that would be another telltale sign. So physicians in these situations are at increased risk for suicide. For all physicians, when the studies have shown that they have 70% higher age-adjusted risk for suicide than the general population. So that's for males, and for females, it's 250% increased risk, age adjusted, for suicide than the general population. Now, when you throw substance abuse into the mix, then you have a problem as well, because now they're becoming despondent. They're doing things that they know are contrary to the values that they held. They're putting their jobs, their lives, their careers at risk, and they become very pessimistic, and they're at higher risk for suicide. And the highest risk is when they're caught diverting. And that is the reason in the story of Dr. Smith that the chief of staff and the department head actually accompanied him to the evaluation, then accompanied him to the rehab center, because that is you don't just let these people go home, because they are very high risk for suicide. Now, why don't they get reported more often? Well, there's lots of factors that are at play that keep these people functionally as addicts and not reported. First of all, the family doesn't want to report them. The spouse may see signs, but really doesn't want to bring it to anybody's attention, because they're afraid that they're going to hurt their spouse's reputation. They may be afraid that then the spouse or the loved one will suffer some sort of adverse action in the work environment, like being suspended from work or something like that. Then they have to worry about disruption of the family income. If they report their loved one, then they may be suspended from the staff or be fired altogether, and then they will be financially unstable. And also the shame of it, right? Everybody's proud of their spouse's achievements, and there's hidden shame that accompanies it. Colleagues are reluctant to report as well because first of all, they're not trained to see these signs of abuse. We work long hours. People come in looking disheveled and tired because they've been on call. Well, how is that any different from being a substance abusing physician? They are hesitant to interfere. They go, well, I come to work every day. It's not my business that I know that my colleague is abusing alcohol and going home and drinking at night. It's not my business. I shouldn't really get involved. And then, of course, there has been historically in medicine that conspiracy of silence. The mistakes happen, things happen, and we tend to just brush it under the carpet. And then also, physicians have to be worried about litigation. If what happens if they have suspicions, they report it, they turn out to be completely wrong, and the accused physician comes back and sues the doctor for destroying their reputation. So these are all areas in which physicians tend to remain hidden, abusing drugs and not report it. But then once they are, just like in the story of Dr. Smith, there is an intervention. And this is what's important, and how we do it is also important. As I mentioned, you want to make sure that you confront them, usually in the morning when they're not high on any drugs, and then give them, support them, but at the same time, give them the information that you have that leads you to believe that they're diverting drugs. And then accompany them to the evaluation, accompany them to the rehab center. You don't want to let them go home. Number one, they might shoot up. If they shoot up, they may say, well, this is my last hurrah. Let me just shoot more than I usually do. And they may overdose, or they may be so despondent at being discovered that they might commit suicide. So we have to be very, very careful in what we do it, or how we do it. Then once they get to rehab, then they are actually faced with a very difficult road. They have both the medical treatment, the addiction that they have to deal with, as well as the legal process. So we have the medical treatment. They'll undergo intensive therapy. They'll have group therapy with other physicians to talk about it. They'll get enrolled in what's similar to a 12-step program. If they have a coexisting psychiatric disease, they'll be treated for that until they can abstain from drugs. But then they also have the legal process. They will be reported to the medical board. They'll have to hire an attorney and go through the entire process of having their license suspended and then reinstated with conditions. And but the good thing is that they do return to work, usually with a contract of some kind, where they don't work more than certain hours, that they have a monitor, that they can't supervise certain people, and that they do biological testing at least once a week for 5 years. But the success rate is actually pretty good. When compared to the general population, physicians that return to work, the success rate is somewhere between 75 and 90%. General population is about 50%. And part of it is because of the medical board process. The medical board requires that they do regular testing for 5 years, that they continue to have psychotherapy and group therapy, and that they are monitored and they don't work too hard. So they try to bring these people in. Anesthesiologists, they abuse opioids more than any other specialty, but they have very good outcomes. Residents, on the other hand, do not. They have very poor outcomes. So the recommendation for anesthesia residents is that if they are caught diverting, that they perhaps ought to find another specialty to train in. So that is it. That is another population of substance abusing people. And I think the treatment is slightly different and doesn't involve the courts.